Welcome to the deep dive. If you're looking to really understand the language health professionals use when they talk about altered health, well, today we are aiming to crack that code.
Mm,
We are diving deep into the absolute basics from Porth's Essentials of Pathophysiology, Chapter 1,
yeah.
really the essential stuff for getting your head around how and why things go wrong in the body.
Yeah, and our goal today really is to lay down that foundation quickly.
Mm.
We need to define the core terms, the language of disease. We'll
Mhm.
cover everything from what causes illness, how it develops, um, all the way to how we measure and even try to prevent it in, well, entire populations.
Right, because this foundation, it's what connects the dots, isn't it, between those tiny changes inside cells and what the patient actually experiences.
Exactly. It bridges the microscopic to the macroscopic.
So let's start with that language because these key terms, they get mixed up all the time. You've got physiology, that's pretty straightforward, just how the human body functions normally.
Right. Normal function.
Then there's pathology. That comes from the Greek word pathos, which means disease. So pathology studies the structural and functional changes in cells, tissues, organs that either cause disease or are caused by disease.
And when you put those two ideas together, physiology and pathology,
Yeah.
you get our main topic, pathophysiology. It's basically the physiology of altered health.
Ah, okay. So it's not just what changed structurally, but how that change messes up the body's function.
Precisely. It's the synthesis. It answers that key question. How does this specific change in structure, the pathology, actually lead to the dysfunction that affects the whole person?
Got it. Okay, so before we dive deeper into sickness, maybe we should define the opposite. What exactly is health? The World Health Organization had that really famous definition back in, what, 1948?
They did. A state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity.
Complete well-being. That sounds
Well,
aspirational,
mm,
maybe a bit idealistic.
it is a very high bar, yeah.
Yeah.
And it's often criticized for being, well, maybe unrealistic to maintain all the time. You can contrast that with more modern approaches, like the Healthy People initiatives, Healthy People 2020, for instance.
How do they approach it?
They shift the focus more towards measurable, actionable goals. Things like trying to achieve lives free of preventable disease, tackling health inequities, promoting healthy habits throughout life. More practical, you could say.
Okay, so if perfect health is maybe that impossible goal, let's look at how medicine thinks about disease when it happens. You said every disease follows a kind of journey with 6 parts.
That's right. A structured way to think about it. And the first step is understanding the etiology.
Etiology. That's the
Yeah.
cause, right?
Simply put, yes. The cause. And this can be really broad. It might be a biological agent, like a virus or bacteria. It could be physical forces, think trauma from an accident, chemical agents, toxins.
Or things you're born with, like genetics.
Absolutely. Genetic inheritance plays a huge role. Also, nutritional factors, excesses, or deficits. But here's a really critical point. Most of the major diseases we face today, things like cancer, heart disease, diabetes, they aren't caused by just one single thing.
Ah, right. They're more complex.
Overwhelmingly so. They're multifactorial. It's usually a complex mix of genetic predisposition, environmental factors, lifestyle choices,
Uh-huh.
all interacting as risk factors.
Okay, and you mentioned being born with something. We should quickly clarify that distinction, right?
Yeah.
Between congenital and acquired.
Yes, good point. A congenital condition is one that's present at birth. It doesn't matter if the cause was genetic or something environmental that happened during pregnancy. If it's there at birth, it's congenital.
And acquired.
That means it develops after birth. Things like infections, injuries, exposure to toxins later in life,
Hmm.
those lead to acquired defects.
Okay, so etiology is the why. What's next on this disease journey?
Step 2 is pathogenesis. And this is where people sometimes get a bit confused between etiology and pathogenesis.
How are they different?
Well, if etiology is the initial cause, pathogenesis is the mechanism.
Mm-hmm.
It's the actual sequence of events at the cellular and tissue level that unfolds from the moment you first encounter that etiologic agent right up until the disease fully shows itself. It's the step-by-step how the disease develops.
How? Okay, can you give an example?
Sure. The book uses a great one, atherosclerosis or hardening of the arteries.
Okay.
We often say atherosclerosis is the etiology, the cause
Yeah.
of a heart attack.
But
It's but think about atherosclerosis itself. What actually starts that process? The true initial etiology. Well, it's still debated, complex, likely multifactorial, like we said. However, the pathogenesis of atherosclerosis. That we understand much better.
Which is?
It's that whole inflammatory process, how a little fatty streak starts in the artery wall, then progresses, gets inflamed, builds up plaque, becomes calcified, and eventually can become this big lesion that blocks blood flow. That whole sequence, that's the pathogenesis. We know the how pretty well, even if the initial why is murky.
Ah, I see. That's a really clear distinction. So we have the cause, etiology, the mechanism, pathogenesis. What happens then?
Then we look at the results of that mechanism, which brings us to morphology. Morphology means the changes in the basic structure or form of tissues or organs.
Structure and form. So what something looks like.
Exactly. This includes gross anatomic changes, things you can see with the naked eye. The book mentions an example like looking at a brain with atrophy in the frontal lobe. You'd see the folds, the gyri look thin, and the grooves, the sulci, look wide. That's a gross morphological change.
Okay. And it also includes microscopic changes.
Yes, that's where histology comes in. Histology is the study of cells and the extracellular matrix at the microscopic level. Think about diagnosing cancer. Pathologists prepare very thin, stained slices of tissue to look for abnormal cell morphology under the microscope.
So morphology covers both the big picture, like that brain atrophy example, or say how a heart muscle gets visibly thicker, that's myocardial hypertrophy, maybe from long-term high blood pressure.
Right, that's a gross change.
And also the tiny details you need histology slides to see.
Precisely. Gross and microscopic structural changes.
Okay. So we've gone from cause to mechanism to structural changes. Now, how does this show up in a patient?
That brings us to clinical manifestations. This is what we actually observe or what the patient experiences in the clinic.
And these fall into two main types, right? Signs and symptoms.
Correct. Symptoms are subjective. They're what the patient feels and reports. Things like pain, dizziness, feeling short of breath. You, as the observer, can't directly measure their pain level or their dizziness.
Subjective, got it. And signs.
Signs are the opposite. They're objective manifestations. Things that an observer, like a doctor or nurse, can detect and often measure. Think of an elevated temperature using a thermometer, visible swelling in an arm or leg, changes in pupil size reacting to light. These are objective findings.
Makes sense. And sometimes a whole collection of signs and symptoms tend to show up together for a specific condition.
Yes, and when you have a compilation of signs and symptoms that are characteristic of a specific disease state, we call that a syndrome, like chronic fatigue syndrome, for example. It's defined by a cluster of specific symptoms and sometimes subtle signs.
Okay. And what about things that happen later because of the disease or maybe even the treatment?
Those are called complications, or sequelae. They're potential adverse outcomes or extensions that can follow the initial disease process, like nerve damage developing as a complication of diabetes.
Right. So to figure all this out, to put a name on it, you need a diagnosis. And that involves pulling everything together.
Absolutely. Diagnosis is a process. It relies heavily on taking a good patient history, performing a thorough physical examination, PE, to look for those signs, and often using diagnostic tests to confirm or rule out suspected problems.
Now, those diagnostic tests, they give results, often numbers. But what does normal actually mean on a lab report? It's not always straightforward, is it?
Not at all. This is a key clinical insight. When we talk about a normal value or a reference range for a test, we're not usually talking about perfect health. We're talking about statistics.
Statistics, how so?
Think of it like grading on a curve for a large population. A normal range typically represents the results found in 95% of a healthy reference sample population. Mathematically, it's often calculated as the mean value plus or minus 2 standard deviations.
Ah, okay. So if your result falls outside that 95% range, it's flagged, but it doesn't automatically mean you have the disease.
Correct. It just means it's statistically less common. And this is why those normal ranges have to be adjusted sometimes. For example, normal hemoglobin levels are different for women and men. They change with age, too. You have to compare the individual's result to the correct reference group.
That makes sense. So you're comparing like with like statistically. Now, when we choose a diagnostic test, how do we know if it's any good? What makes a test reliable?
Good question. There are several factors we look at to evaluate a test. First is validity. Validity basically asks, does this test actually measure what it's supposed to measure? Is it accurate? The book gives an example like comparing a standard blood pressure cuff, a sphygmomanometer, to the gold standard of directly measuring pressure inside an artery. How well does the cuff measurement reflect the true arterial pressure? That's validity.
Okay, accuracy. What else?
Reliability. Reliability is about consistency. if you repeat the test or observation, do you get the same result? Or if different people perform the test, do they get similar results?
So consistency, but wait, can a test be reliable but not valid?
Absolutely. Imagine a poorly calibrated scale. It might reliably tell you you weigh 150 pounds every single time you step on it. But if your true weight is 160, it's reliable, consistent, but not valid, accurate. Reliability depends a lot on things like equipment calibration and the skill of the person doing the test.
Okay, validity and reliability, important. But then there are sensitivity and specificity, which always seem to come up.
Yes, these are crucial for interpreting test results clinically. Let's take sensitivity first. Sensitivity refers to the proportion of people who actually have the disease and test positive on the test. It measures how well the test picks up true positives.
True positive, so it correctly identifies people with the disease.
Exactly. And the clinical usefulness here is huge. A test with high sensitivity is great for ruling a disease out. If a highly sensitive test comes back negative, you can be pretty confident the person doesn't have the disease. Think cone out. Sensitive negative rules out.
Cone out. Okay, I'll try to remember that. So what about specificity?
Specificity is the flip side. It measures the proportion of people who do not have the disease and test negative. It measures how well the test identifies true negatives.
True negatives. Correctly identifying people without the disease.
Right. And high specificity is vital for reeling a disease in. If a highly specific test comes back positive, you can be more confident the person does have the disease. Think SPISN. Specific positive rules in. High specificity helps minimize those worrying false positives.
False positives. Yeah, those cause a lot of anxiety and extra testing. SPIPIN. Okay. Sensitivity and specificity. Critical concepts. Now, once a diagnosis is made, how do we describe how the disease behaves over time?
That's describing the clinical course. Diseases evolve differently. An acute condition is usually relatively severe but tends to be self-limiting, meaning it runs its course. Think of the common cold.
Okay. And chronic.
A chronic condition is one that persists over a long time, often continuously or with ups and downs. It might have periods where symptoms get worse, called exacerbations, and periods where they lessen or disappear, called remissions. Arthritis is a classic example.
And is there anything in between?
Yes, sometimes we use the term subacute, not as severe or sudden as acute, but not as long-lasting as chronic, kind of an intermediate state.
Got it. And do diseases always show obvious signs and symptoms?
Not always. There's actually a whole spectrum of how a disease might present. It could be in the preclinical stage. Here, the disease isn't clinically evident yet, but is destined to progress and show up later. Importantly, sometimes people in this stage can still transmit the infection even without symptoms.
Preclinical. Okay. What else?
Then there's the subclinical stage. In this case, the disease is present, maybe causing some biological changes, but it's not noticeable clinically and doesn't produce obvious symptoms. It might only be detected through lab tests or imaging. A lot of tuberculosis infections, for example, remain subclinical.
So it's there, but quiet.
Exactly. And finally, you can have a carrier status. This is someone who harbors an organism like bacteria or a virus and can transmit it to others, but they don't actually show any signs or symptoms of being infected themselves.
Wow. Okay. So understanding the disease in one person involves all these steps: etiology, pathogenesis, manifestations, diagnosis, clinical course. But how do we take this knowledge and apply it to, well, everyone, to population?
Now you're asking about epidemiology. That's the field that studies how diseases occur in human populations. It looks at the patterns, causes, and effects of health and disease conditions.
So zooming out from the individual patient to the whole community?
Precisely. Epidemiology is what public health professionals use to understand how diseases spread, who is at risk, how to control outbreaks, where to allocate healthcare resources, and how to design prevention strategies. It shifts focus from individual risk factors to population-level risk.
Okay. And how do epidemiologists measure disease frequency in populations? I know there are specific terms for that.
Yes, two fundamental measures are incidence and prevalence. They sound similar, but they measure different things. Incidence is the number of new cases of a disease that arise in a population at risk during a specific period of time.
New cases. So it's about how fast the disease is occurring.
Exactly. Incidence is a measure of risk. It tells you how likely people in that population are to develop the disease over that time period.
Okay. Risk. And prevalence.
Prevalence is different. It measures the number of existing cases, both old and new, in a population at a specific point in time, or sometimes over a period. It's like taking a snapshot.
Existing cases. So it tells you how widespread the disease is right now.
Yes. Prevalence gives you a measure of the burden of the disease in the population at that moment. The key thing to remember is incidence reflects risk of getting the disease, while prevalence reflects how many people have it. A disease could have low incidence, not many new cases, but high prevalence if people live with it for a very long time, like many chronic conditions.
That distinction is really important. Burden versus risk.
Okay, and how do we track the impact, the consequences of these diseases in populations?
We use measures of morbidity and mortality. Mortality is probably the one people are most familiar with. It refers to death. Mortality statistics track the causes of death in a population, usually expressed as death rates, sometimes adjusted for age or specific groups like infant mortality.
Death rates. Pretty clear. What about morbidity? Morbidity is about the effects an illness has on a person's life. It's concerned with illness, disability, and the functional consequences of a disease. It looks at the persistence of symptoms and long-term impacts on quality of life.
So not just death, but the burden of illness itself.
Exactly. Often, the biggest public health challenges aren't necessarily the diseases with the highest mortality, but those with high morbidity. Think about something like chronic arthritis or persistent back pain. They might not kill many people directly, but they cause widespread suffering and disability, impacting millions of lives and the economy. Morbidity captures that burden.
That's a really important perspective. Okay, so epidemiology helps us measure frequency and impact. How does it help figure out what factors contribute to these diseases in the first place? Identifying those risk factors we talked about earlier.
Epidemiologists use different types of study designs to investigate risk factors. One common type is a cross-sectional study. Here, you basically take a snapshot of a population at one point in time and collect data on both exposures, like smoking, and outcomes, like heart disease, simultaneously. You can then compare the prevalence of the outcome in those exposed versus those not exposed.
A snapshot comparison. Okay, what else?
Then there are case control studies. These are retrospective. You start by identifying people who have the disease or outcome, the cases, and a comparable group who don't have it, the controls. Then you look back in time to compare how frequently the suspected risk factor was present in the cases versus the controls.
Looking backwards from outcome to exposure, are there studies that follow people forward in time?
Yes, and those are often considered the strongest for identifying risk factors. They're called cohort studies or longitudinal studies. In a cohort study, you identify a group of people, the cohort, who are initially free of the disease you're interested in. You assess their exposures, and then you follow them over time, sometimes for many years or decades, to see who develops the disease.
Following them forward. That sounds like a lot of work.
It is, but it gives you powerful information about incidence and risk. Probably the most famous example is the Framingham Study. It started way back in 1950, enrolled thousands of people in Framingham, Massachusetts, and followed them for generations. It's been absolutely fundamental in identifying major risk factors for coronary heart disease, things like high blood pressure, high cholesterol, smoking.
Wow, decades of data. Any other big ones?
Another huge one mentioned is the Nurses' Health Study, which started in 1976. It followed over 100,000 female nurses, looking at things like oral contraceptive use, diet, lifestyle factors, and their links to chronic diseases. These massive long-term cohort studies are invaluable.
They really shape our understanding. And the data from these studies helps define something called the natural history of a disease.
Yes, exactly. The natural history describes the progression and the likely outcome of a disease if there's no medical intervention. Understanding this baseline is crucial. It helps us decide when screening is beneficial or provides a benchmark against which we can compare the effectiveness of new treatments. The book mentions hepatitis C, knowing that 75–85% of people infected progress to chronic infection helps prioritize screening and treatment.
Knowing what happens without treatment informs how we treat, and that leads to prognosis.
Right. Prognosis is the predicted outcome and the prospect of recovery from a disease. It's usually discussed in the context of the diagnosis and the available treatment options, considering the risks and benefits.
Okay, so we have all this knowledge about the disease process, how to diagnose it, how it spreads, its natural history. What's the ultimate goal? How do we use this knowledge?
The application really is prevention, using this understanding to stop disease from happening or progressing. And we usually think about prevention in three distinct levels or tiers.
3 tiers. What are they?
First is primary prevention. The goal here is to remove risk factors entirely to prevent the disease process from even starting. This is about keeping people healthy in the first place.
Okay, examples.
Think about immunizations. They prevent infectious diseases. Giving folic acid supplements to pregnant women helps prevent neural tube defects in the baby. counseling people on healthy diets and exercise to prevent heart disease or diabetes. You're tackling the root causes before illness occurs.
Removing risk. Got it. What's the second level?
Secondary prevention. This focuses on early detection of disease when it's still asymptomatic or in its very early stages. The aim is to intervene early enough to cure the disease or significantly slow its progression.
Early detection, like screening tests. Exactly. Pap smears for detecting early cervical changes, routine blood pressure measurements to catch hypertension early, colonoscopies for finding precancerous polyps. These are all secondary prevention strategies. You're catching it early while it's potentially curable or manageable.
Okay. Primary is preventing it from starting. Secondary is catching it early. What's the third tier?
Tertiary prevention. This comes into play once a disease is already established and often symptomatic. The goal here isn't necessarily cure, but rather to implement clinical interventions that prevent further deterioration, reduce complications, or minimize disability from the existing disease.
Managing an existing disease. Examples.
Prescribing beta blocker medication after someone has a heart attack to prevent future heart problems and limit damage. Setting up support groups for people recovering from addiction to help prevent relapse. Rehabilitation programs after a stroke. It's about improving function and quality of life when the disease is already there. Right, preventing things from getting worse. Those three levels make a lot of sense. Now, all this information from the lab, from epidemiology studies, from clinical trials on prevention, how does it actually make its way into everyday medical practice?
That's where the concept of evidence-based practice, or EBP, comes in. It's a fundamental shift in healthcare thinking. EBP means making clinical decisions based on the best available scientific evidence, rather than just relying on intuition, anecdotal experience, or simply how things have always been done.
So moving away from tradition towards data.
Precisely. EBP requires practitioners to integrate their individual clinical expertise with the best external clinical evidence derived from systematic research. It's about consciously using the current best evidence when making decisions about patient care.
And how is that evidence compiled and shared?
One major way is through clinical practice guidelines. These are systematically developed statements designed to assist practitioners and patient decisions about appropriate health care for specific clinical circumstances like managing high blood pressure or treating asthma.
So like official recommendations based on the research.
Exactly. And importantly, these guidelines aren't static. They are constantly being reviewed, updated, and sometimes completely changed as new research emerges. Sometimes this involves complex statistical techniques like meta-analysis, which combines the results of multiple studies to get a more robust answer. This whole process ensures that practice aims to keep pace with the evolving science.
That constant updating seems crucial. Okay, wow. We've covered a lot of ground there, really building that foundation. Just to recap quickly for everyone listening, we define pathophysiology as that link between structural change and functional impact. We walked through the key steps in understanding any disease, the cause, etiology, the mechanism, pathogenesis, the resulting changes, morphology, and how it shows up, clinical manifestations, signs, and symptoms.
Right. And we talked about the importance of rigorous diagnosis, including understanding test properties like validity, reliability, and especially the clinical power of sensitivity for ruling out disease and specificity for minimizing false alarms.
Then we zoomed out to epidemiology, looking at population measures like incidence, risk, and prevalence burden, and the different study types like cohort studies that help us understand natural history and risk factors.
And finally, we tied it all together with the goal of prevention, primary, secondary, and tertiary, and the absolute necessity of using evidence-based practice and continually updated guidelines to make sure we're applying the best current knowledge.
It lays out a really clear framework.
It does. And, thinking about that constant evolution of evidence in EBP, it raises a really important closing thought, I think. Given that guidelines for things like asthma or hypertension do get revised, sometimes significantly based on new research, how does the healthcare system ensure it not only adopts these new best practices quickly, but maybe just as importantly, how does it systematically let go of the old practices that the new evidence shows are ineffective, or maybe even harmful? That challenge of constantly updating, of embracing that dynamism where today's right answer might be outdated tomorrow, that's maybe the most crucial mindset for anyone going into healthcare to grasp.
That's a fantastic point to ponder, the need to constantly learn, adapt, and sometimes unlearn based on evidence. A perfect thought to end on. Thank you so much for walking us through all that.
My pleasure.
And thank you for joining us for this deep dive into the absolute fundamentals of pathophysiology. We really hope you feel better equipped now to connect those dots between what's happening at the cellular level and the health of the patient in front of you, or the health of the whole community. We'll see you next time on The Deep Dive.